Thank you for watching our presentation titled Comparing Nursing Students' Perceptions of Learning Across Three Clinical Learning Environments. I'm pleased to present on behalf of our author team, and my name is Kim Layton, and I manage a large simulation center in the Middle East. Our other authors are Colette Foisy-Dahl, who is the director of a simulation center in Canada, Dr. Susan Cardon-Egren, Associate Professor of Health Professions Education in Boston, US, and Dr. Tanya Sneederreith, Associate Professor at a university in Maryland in the US. Our international team also acknowledges the statistical support given by Katie Wusney. We have no conflicts of interest and receive no financial support for this work. Following this presentation, you will be able to discuss the undergraduate nursing students' perceptions of how well their learning needs were met in the traditional clinical, face-to-face simulation, and screen-based simulation learning environments. And you'll be able to support efforts to improve specific areas of the screen-based simulation experience. This study was triggered by the COVID-19 pandemic, when nursing educators were forced to replace their usual ways of clinical teaching. Now, although many educators were already using virtual simulation, most had to replace traditional clinical practice experiences too, so that students could meet regulatory requirements for progression and graduation. Screen-based simulation was one method for providing clinical education, as this allowed safe, clinically based learning opportunities for students. With screen-based sim, students could provide care for graphical representations of human patients on a computer screen through a keyboard, mouse, or other input device. Screen-based sim allows for feedback and assessment when an instructor may or may not be present. There were many vendors who provided free or discounted products during the pandemic, and educators also were very creative in how they moved simulation activities online. There are many comparison studies between the traditional clinical and face-to-face simulation learning environments that have been done because we've been trying to learn more about simulation. For example, the impact of discrete aspects like design, debriefing, and fidelity on specific outcomes such as critical thinking, clinical reasoning, prioritization, and communication. We found only one instrument that compared how well students' learning needs are met in the traditional clinical and face-to-face simulation environments, but none that also compares screen-based simulation. The Clinical Learning Environment Comparison Survey, or CLECS, was reliable and valid when used with pre-licensure nursing students. We adapted the CLECS with permission so that we could compare the three learning environments, and it was renamed the CLECS 2.0. Our research question was, how well do the students believe their learning needs were met in the traditional clinical, face-to-face simulation, and screen-based simulation learning environments? We used a quantitative descriptive study design, capturing data with the CLECS 2.0. As learners were now at home, since most nursing schools had closed campuses, we used snowball sampling through social media sites. The only inclusion criteria was that students needed to have cared for at least one patient in each of the three environments between January 1 and June 30th of 2020. Now, we did have quite a lot of not applicable responses for some of the CLECS 2.0 items, and our statistician advised that we only include cases that did not respond not applicable to any of the items in order to ensure a more valid comparison of the clinical settings. We had 113 complete responses from three countries, namely the United States, Japan, and Canada. The majority were in baccalaureate programs for a mean time of 20 months. Most were females with an average age of 27. There were no correlations between the item scores in any of the settings and these variables. But most importantly, all learning needs were perceived to have been better met in traditional clinical than either face-to-face simulation or screen-based simulation. Now I'll share with you some of the reasons why we believe the screen-based simulations scored lower. The CLECS has 6 subscales, including communication, nursing process, holism, critical thinking, self-efficacy, and teaching learning dyad. While our sample size was unfortunately not large enough to run confirmatory factor analysis for the CLECS 2.0, our discussion is based on the items grouped into these subscales. The items in the communication subscale are listed on the left. Now, in screen-based simulation, the level of artificial intelligence needed for real-time conversations is just not yet available in most programs, while the traditional clinical environment is full of real people to talk to. This allows learners to participate in patient, family, and clinician encounters that occur in real time. Interacting with the patient was also significantly less met in face-to-face simulation, where learners are aware of the artificial and predictable environment. Now, the nursing process is a dynamic and creative problem-solving process that may be hard to replicate in screen-based simulation. The learners may not have had the opportunity to exercise all 5 phases of the nursing process, including assessment, nursing diagnosis, plan, implementation, and evaluation in a way they recognized or that felt natural. Mimicking the chaotic, complex, and unpredictable nature of the real clinical environment is difficult. The holistic aspects of patient care have seen low scores each time the CLECS has been administered. Holism encompasses the physical, psychological, or psychosocial, spiritual, cultural, and developmental aspects of our patients. While these aspects are likely more obvious when caring for and conversing with our real patients, they are easily replicated in the simulation environment through the use of prompts and scripted conversations. Consider learners caring for a patient having a myocardial infarction. If the patient is 35 years old, works construction, and has 4 young children at home, the nursing student will learn to provide care for more than just his physical heart. A picture frame at the bedside with a photo of a large family could easily prompt the conversation. Critical thinking is the basis of clinical reasoning and judgment. During patient care, learners have to decide if an action is required and whether they should use a standard approach, modify their approach, or even improve and create a new approach based on the patient's needs. The nuances of critical thinking may be difficult to discern in screen-based simulation, other than noting if the right actions were taken or steps were completed in the right order. Self-efficacy, specifically confidence in decision-making and abilities, as well as calmly reacting to changes, scored significantly lower in screen-based simulation. These programs often have asynchronous designs where learners and instructors can access the programs at different times. The ability to get immediate feedback from peers and staff may be an important missing activity. In traditional clinical, we also have post-conferences, as well as a pre-conference, where learners can check their understanding of the patient care expectations. In face-to-face sim, we debrief in person, and we also have pre-briefing and preparation activities, which may play a role in bolstering perceptions of self-efficacy. Not knowing how to respond to an error may indicate that options provided in screen-based simulation are too obvious or follow patterns, and more study is warranted on this. Now, the availability of the instructor to the learner has been found to be very important in the traditional clinical and the face-to-face simulation environments, but this looks very different in screen-based sim due to the often asynchronous nature, as well as the physical distance and barriers between instructors and learners. It may be important for students to have preparation activities and pre-briefing prior to screen-based simulation, just as in other clinical environments. We didn't ask specific questions about this. However, the role of the faculty needs to be considered. We have shared with you just some of the interpretations of our data. It's important to remember that there are many complicating factors for the move to screen-based simulation during a pandemic. Many faculty had to move simulation online in a matter of hours. Many had never taught online, so did not have experience teaching in that environment. Additionally, excuse me, although many had used screen-based sim products and most vendors gave their products for free, there still needed to be time to learn how to use them and to teach students how to use them. Many of these products have extensive analytical features that benefit faculty. We also posit that the standards of best practice for simulation by the International Nursing Association for Clinical Simulation and Learning should apply to screen-based simulation. The same pedagogical rigor must apply, especially as regulatory bodies are allowing hours spent in screen-based simulation to replace traditional clinical and face-to-face simulation hours for progression and graduation. So faculty development really must be a priority. The study had several limitations. While snowball sampling is an acceptable recruitment strategy, we were not successful in getting student-facing social media sites to post our study information. We then had to rely on faculty and simulation sites to reach our students, and that introduces a risk of bias. The composition of the final sample is also unknown. The sample or the small sample size results in an inability to generalize findings, as well as an inability to conduct reliability analysis of the CLECS 2.0. So future studies we recommend should consider types of the screen-based programs used, faculty or facilitator training for implementation, support received, understanding of best practices for online learning, and competency in using programs and technology. Now, we also chose to keep the original definitions of the CLECS subscales because student learning needs really haven't changed in the clinical environment. However, this should be considered in future study, particularly changing critical thinking to clinical reasoning. In conclusion, screen-based simulation scored lowest for every CLECS 2.0 item, which is very concerning as discussion over whether screen-based sim can replace traditional clinical hours unfolds. While our study took place in a pandemic and screen-based simulation is often a self-guided experience, faculty still must be responsible for the pedagogical expectations of simulation, including pre-briefing, conducting a dry run, ensuring the learning objectives are at an appropriate level, and debriefing. Faculty are really encouraged to complete the screen-based sim prior to assigning it to students, just to ensure the learning needs align with the curriculum. Our findings support the need for concentrated efforts to improve these specific areas of the screen-based experience. We're also studying the not applicable findings to see if they provide insight into the design of screen-based simulation. Thank you for listening to our presentation. Here is my contact information. If you have any questions at all, I'm happy to respond to you. The CLECS 2.0 is also freely available for download on my website, Evaluating Healthcare Simulation. And the website is on the slide. It's sim-eval.org. And our paper has just been published, and the citation for that paper is also noted here on the slide. Our references follow on the next slide. And again, thank you for attending our presentation.